Thanks, Rod, and thanks everyone for giving me a patient hearing post-lunch. I'm assuming it'll be patient. So in 2015, towards the end of the year, this picture became something that everybody across the state, perhaps the country, maybe even the world became familiar with. This is the front of Bacchus Marsh Hospital. The cross there is not a Christian cross, it's actually a war memorial. Before I carry on, there are 3 people in this room that I would like to acknowledge very specifically. They're 3 midwives, Tracy Hines, Sarah Watts, and Pauline Carricker, who's somewhere here. None of this work would be possible without these 3 very fabulous women. So clearly there was a need for change. There was a need for change at Bacchus Marsh, but we will all acknowledge that there was a need for change across the sector. Probably one of the first things that happened was that traffic lights arrived in a small town with 1 street that had no need for traffic lights. These traffic lights to us were initially more about excluding people than including people. And I'm sure all of you have gone through a traffic light system to determine your capabilities. And the starting point always seems to be, who can we say no to? And that, to me, seems like not the ethos that we started out in healthcare for. We're about saying yes to people, not saying no to people. So just hold that thought, because we started out by saying no to people. We said no to a whole lot of people who had previously had their babies with us, because now suddenly they didn't fit into our capability framework. One of the first obstetric M&M meetings with open entry to all staff was held in early 2016. This was revolutionary for our unit. All our M&Ms had been held behind closed doors with a few people involved. The staff never got to know what was discussed here. There was no feedback from this, so nobody ever realized what improvements were needed. So the first M&M, a few midwives came along. They were very, very scared. They thought, oh my God, we're going to get questioned. What's this going to be like? Will it be an interrogation? None of that happened. We all just sat together, had a discussion, and went, you know what, we could have done this better. How can we improve things? And it was a learning experience for everyone to be able to talk to each other, which we don't do very well in most health services. FSEP arrived with a bang. Mandatory yearly competency with level 3 requirements for all obstetricians, all midwives who worked in senior positions. And it took some of our senior midwives 4 goes before they got to level 3. We'll talk about whether FSEP actually made a difference. Prompt training was the next one. So again, annual mandatory prompt training for all staff members. Didn't matter if you were senior, junior, doctor, midwife, head of obstetrics, junior registrar, HMO, everybody did the same FSEP and the same prompt, and we did it together. You've already seen that little photograph on Nicola's presentation. That is me learning how to do a symphysiofundal height correctly as part of the fetal growth restriction workshop. I learned it because I had learned to do it wrong all my life. But I was very happy to admit that I'd learned it wrong all my life, and this was the right way to do it, and I was willing to change. Recognizing that ultrasound plays such an important role in all of the decisions we make, and recognizing that if you don't have a good quality ultrasound, you can't actually provide the care that you want to provide, is a huge implication for a small health service which has an external ultrasound provider. So the first step was engaging the external provider, telling them what we wanted, getting them to standardize their reports from telling us that this baby's femur length was 34 weeks and 3 days, and abdominal circumference was 32 weeks and 2 days, and head circumference was 31 weeks and 1 day, which made no sense to any of us, didn't help us in our decision making. We actually got them to change how they reported their ultrasounds to make them more relevant for our practice, to make them more helpful for our practice. We invited them to come to our M&Ms so that they could see the impact that their reporting had on what we were doing for women. We couldn't do anything on our own because we're a small health service. Luckily, Sunshine Hospital up the road came to our rescue and acted as our experts for those difficult cases where we needed a second opinion, for fetal medicine, for obstetric medicine, all of those things. And we're very grateful to them. Of course, whiz-bang technology arrived as well. We got the state's best, latest CTG monitoring system with remote access. I could sit in my bed at midnight and look at all the CTGs running on the labor ward. I didn't want to. We got a brand new ultrasound machine. We learned how to use it because it was so new that we had not used it previously. The reason I put that slide up is because all of this is great. Lots of education, technology that helps. But what I want you to think about is, why are you here? We're all healthcare providers. What matters to us? Yes, it matters that we're appreciated for what we do. We're helped in maintaining our skills, and education comes into that. We would like to be rewarded, and I will be the first one to say that I speak for the majority of you here, that that reward is not monetary. The reward is what our patients tell us. Those little cards that we hang on to for the rest of our lives that say thank you for being with me, or whatever it is that they say. Promotion is good because it acknowledges that we've acquired new skills and it gives us more responsibilities. And it empowers us to hopefully make a change for the better in the greater health system. So, was there a miracle ahead? We had everything there, good technology, mandatory training, friends to help us. Did we actually make a difference? Now, you've all read the PSPI report, so I can't lie to you. I would love to stand here and say, yes, the miracle happened and we were fabulous. But what the PSPI report clearly says is that our induction rates were fairly high, very high. Our cesarean section rates were also high. Our third and fourth degree perineal tear rates were also high. So why has the miracle failed us? Or is this actually a failure of a miracle? Or are we looking for something else? I've borrowed this slide from a mentor of mine from the UK who runs a program called Whose Shoes, which is about involving women in maternity care. So it gets together a group of either pregnant women or women who've recently had a baby, gets them to talk to each other and talk about their experience, what they thought they would be getting, what they wanted out of that experience. And this is just a combination of things that people wanted. And you can see what it says in those bold, big letters. Women want quality, they want to be supported, they want to have choice, they want control, they want good language and communication, they have high expectations, they want a lovely environment, they want utopia, don't they? But in the center of all that is that they want inclusion. So a simple philosophy of no decision about me without me is a good guiding principle, because that's what women want. And I don't think the women in Australia would be that different from women in the UK or women anywhere else in the world. Which brings me on to a couple of new indicators in this report. So indicator 11A and 11B. 11A is the rate of women who felt involved as much as they wanted to be in the decisions about their care in labor and birth. And we were the highest in the state. Moving on to 11B, consistent advice about breastfeeding or feeding their baby, highest in the state. And if you all cast your glance to those tubes there, the tube that is the most full is indicator 11. Because all of us are here because we didn't choose this profession to provide good data. We chose this profession because we care. We chose this profession because we want to listen to women. Some of us want to advocate for our women. We want to be there with our women and families. So I put to you, if we change the narrative of looking at our data from actually a patient's point of view, does it matter to me if you tell me that the cesarean section rate in your hospital is 30% for a standard primip? I don't understand what a standard primip is. I don't care what a standard primip is. I'm a unique woman. I don't want to be a standard primip. I want to know if you will listen to me. I want to know if you will involve me in those decisions that you make about my pregnancy, about my baby. I want to know if you will give me open and honest information and point me in the right direction if you can't give me that information. When my baby is born, I want to know if you will give me the right information about feeding the baby and if you will sing as a choir from the same hymn sheet, or will you sound like a cacophony? So the challenge for us is to change that narrative from looking at data as data to looking at it from a woman's point of view, from a family's point of view, and from the point of view as healthcare providers who want to make a difference. I want to invite you to come and see our fabulous new maternity unit. If you don't want to see our maternity unit, we don't have the best GSPMR in the state. We do have the best strawberries in the state. They are fabulous. And you'd be very welcome to follow us on social media. Thank you.